Okay, good afternoon, everybody. Thank you very much for coming to this session. I'm going to talk about stereotactic radiation for GU cancers, focusing on prostate and kidney. I have some disclosures. I do collaborate with some pharmaceutical companies, but not related to the content of this talk. So there's three topics I'm going to talk about. I'm going to talk about SBRT for primary prostate cancer, and then I'm going to talk about SBRT for oligometastatic prostate cancer, and then the last topic is SBRT for primary renal cell carcinoma. So I'll go through data and what I do for each of these topics. Just so that I understand, how many of you have heard me talk about these topics before? Because I've lectured on these topics before, but how many have? Okay, good. Well, perfect. Okay. So I'm going to just jump into the first topic. So SBRT for prostate cancer, I really feel that there's now a lot of data supporting the use of SBRT for prostate cancer, and it's actually a treatment that I offer a lot to my patients. There are now a lot of published prospective phase 2 data supporting SBRT, and there's also now phase 3 trials that have been published as well. Just for the sake of time, I'm only going to describe a couple of papers in detail, really, but there's really a lot of data supporting offering this for patients. I think one of the best publications on SBRT for prostate cancer is this paper by Kishan, published in JAMA Open a few years ago. And the reason I think this is a very good paper is because it's prospective data and it showed long-term outcomes. And so what they did is that they pooled data from multiple prospective phase 2 trials from multiple institutions using SBRT for prostate cancer. And combining all of these patients together for this analysis, they had a total of 2,000 patients who were treated on different phase 2 trials, SBRT for prostate cancer. Half of it was low risk, but they also have some favorable intermediate risk and some unfavorable intermediate risk. Most of these patients received radiation alone. Only 5% received ADT. These are very early patients who were treated with SBRT in 2012. This is a very early years of SBRT. And that's important because back in this time, SBRT is very high dose per fraction. Back in this time, there's not very well established dose constraints for normal tissue. So probably the toxicity in these early experiences probably higher than what we see today, because now we have very well described dose constraints for SBRT, but back then there was not. There's follow-up for this study was about 7 years. I like to show this paper because this paper now shows 10-year results of prostate SBRT. This is really long-term follow-up. And what you see is what they report, and this is a prospective study, biochemical recurrence at 10 years was 8.6% for low risk, 13% for favorable intermediate risk, and 18% for unfavorable intermediate risk. And these are really good numbers for low biochemical recurrence at 10 years for SBRT, probably very similar to IMRT numbers. And it shows long-term good results of disease control. And distant metastasis at 10 years, very, very low. So this seems to demonstrate SBRT being effective for these patients. They also report long-term toxicity at 10 years from SBRT, and there's some grade 2 GU toxicity, there's some grade 2 GI toxicity. Grade 3 at 10 years is only 3% GU. Grade 3 GI was only 0.5%. And this is already very, very low, grade 3 to 4 toxicity. But again, this is back when there's no established dose constraints for normal tissue. So with modern SBRT, with established dose constraints, with spacer placement, these numbers were probably even lower. But this demonstrates that SBRT is very safe for prostate cancer treatment. The kind of toxicities patients have, remember this study had 2,000 patients. Out of 2,000 patients, 4 patients had acute urinary retention that required a catheter. 17 patients had urinary retention late toxicity that required a TURP. That's less than 1% of 2,000 patients. So that's very, very low urinary retention. Hematuria, 1 acute, 12 late. That's about 0.5% late toxicity with hematuria. 7 patients had stricture. 7 out of 2,000 is about 1/3%. Very, very low toxicity rates from early experience of SBRT. Rectal bleeding, 5 patients out of 2,000 without spacor. Fistula, 1 patient out of 2,000. So this study shows that long-term outcomes, both in terms of curing prostate cancer and toxicity, GI and GU, very, very good outcomes. And this is a prospective phase 2 type experience. So based on that paper, my interpretation is that SBRT is highly effective and safe for patients with low and intermediate risk prostate cancer. No increased toxicity through 10 years of follow-up compared to other types of radiation. And again, this is based on early adopters without established dose constraints or without standard techniques for SBRT back in 2000. With modern SBRT, with dose constraints and better setup, I think the toxic outcomes are going to be even lower than this study. So very, very safe. We now have randomized phase 3 data supporting SBRT. PACE-B was published in New England Journal of Medicine last year. PACE-B is a large randomized trial of 874 patients. They included low or intermediate risk prostate cancer. If it's intermediate risk, 3+4 is okay, but no Gleason 4+3. And the randomized trial compared SBRT to either conventional fractionation or moderate hypofractionation, and no hormone therapy, so this is a radiation alone trial. The primary endpoint was freedom from biochemical clinical failure. And so they were trying to see if SBRT is non-inferior to longer fractionation for biochemical clinical failure. I think it's important to talk about how they did SBRT, and we're going to talk a little bit about my technique as well. But in this trial, PACE-B, MRI was recommended as part of treatment planning, but not required. Fiducial markers were done for only 3/4 of SBRT patients. I think that's low. I always use fiducial markers. I think it's really important to use fiducial markers for SBRT. So this is kind of low. It should be 100%, but it wasn't 100% in this trial. The CTV for SBRT was the prostate, and they added a centimeter of seminal vesicles if it's intermediate risk. PTV expansion was 4 to 5 millimeters all around, 3 to 5 millimeters posterior. That's pretty much what I use as well. And they prescribed CTV to 40 gray in 5 fractions, PTV 36.25 in 5 fractions, and 1 to 2 weeks, which means that in 5 fractions you can deliver every day or every other day, physician choice. I think some of these details are important. So in terms of the patients that were enrolled in PACE-B, about 80% of patients had Gleason 7 disease, so this is mostly intermediate risk with very few low-risk patients. And actually, a lot of these patients were unfavorable intermediate risk, is what was included on this trial. They had very few patients with large prostates. So prostate size 40 to 80 cc's, but more than 80 cc's were only 5% of patients. So they did not have a lot of large prostates for SBRT. So when they published this paper last year in New England Journal of Medicine, this is the disease outcomes, 5-year freedom from biochemical or clinical failure, 96%, 95%, really no different. Distant metastasis, freedom from distant metastasis, 98%, 99%, disease specific 100%. So this study showed that SBRT is non-inferior to moderate hypofractionation or conventional fractionation, no ADT. So the biological dose is about equivalent between this and this. They also report 5-year toxicity rates for GI toxicity, grade 1, 2, and 3, GU toxicity, and erectile function, and pretty much they were the same also. So SBRT and longer fractionation, very similar GI, GU toxicity, and erectile dysfunction. I'll show it in this plot. So this is a plot of GU toxicity. This is over time. This is grade 1 GU toxicity, SBRT versus conventional fractionation or longer fractionation. And then this is grade 2 toxicity, SBRT, and the blue is longer fractionation, and the bottom pair are grade 3 toxicity. And then this is GI, grade 1, SBRT versus longer fractionation, grade 2 and grade 3. What you see in terms of toxicity in this randomized trial is that for SBRT, there's a higher rate of grade 1 toxicity at about 1.5 years compared to longer fractionation, and a little bit more grade 2 toxicity about 1.5 years compared to normal fractionation. But before 1.5 years and after 1.5 years, the toxicity rates are about the same for GU, and GI toxicity pretty much the same in the two arms. And this is actually what I see clinically. For my SBRT patients, I see at about 1.5 years, there's a bit of a GU symptom flare, almost like a PSA bounce, but not related to that. But there's a symptom flare about 1.5 years for SBRT patients, and then it gets better over time. So SBRT seems to have a little bit more GU toxicity at this time point, but then no other difference in toxicity between the two arms. They also assess patient-reported quality of life. This is not meant to be read, but they use EPIC 26 to look at urinary symptoms, bowel symptoms, sexual function, and it's pretty much the same in the two arms across the quality of life domains. So this is a very large randomized trial, and my interpretation of PACE-B is that this provides strong evidence that SBRT is biologically equivalent to conventional fractionation or moderate hypofractionation for low endometriosis prostate cancer, which is what's included in this trial. SBRT had more GI and grade 1 and grade 2 GU side effects at about 1.5 years. That's a symptom flare compared to longer fractionation, but there's no other difference in GI, sexual, or late GU side effects comparing the two arms. So I really think that this provides very strong data that SBRT should be considered a standard option that we offer to our prostate cancer patients. I actually know that there's another large randomized trial comparing SBRT to moderate hypofractionation, this phase 3 NRG-GU005. They will report data at this year's ASTRO. So we have more and more phase 3 randomized data showing that SBRT is a very good option for prostate cancer patients. So how do I do prostate SBRT? I select patients with low or favorable intermediate prostate cancer, usually. Now, the PACE-B trial had unfavorable intermediate risk, and it showed that SBRT and longer fractionation is the same biologically, but I actually prefer to use IMRT and brachytherapy and ADT for unfavorable, because I feel like ASCENT-RT shows that combination therapy is better for higher risk patients. So for unfavorable intermediate risk, I offer IMRT and brachy and ADT. For low and favorable intermediate risk patients, I usually offer SBRT as my first option. I no longer offer IMRT for these patients. There's no reason to go longer when they can just have 5 treatments. No prior TERP for patients who I offer SBRT, and I have a size limit of 100 cc's for SBRT eligibility. How I plan SBRT, I do similar to PACE-B. So I do 8 grade times 5 for the CTV, which is prostate and up to 1 centimeter seminal vesicles. I do 7.25 times 5 for my PTV, and with a 5 millimeter expansion all around and posterior 3 to 5. This is very similar to PACE-B. I use daily treatment, so I treat patients Monday through Friday. They're done in 1 week, and they're very happy. There's no reason to treat them 5 or 6 weeks when 1 week is just as good. Some people do every other day, and that's also fine, but I do every day, 5 days. We always use fiducial markers for SBRT. I think that's important. I use Calypso, which is a tracking product, but you don't have to use Calypso. I think regular fiducials is fine. I always put in a rectal spacer for my patients. Simulation, VAC-LOCK, I use a catheter for simulation so I can calculate the urethral dosimetry. I treat patients with bladder comfortably full, empty rectum. I recommend daily enema for those 5 days of treatment. And then daily CBCT, I use Calypso tracking, but you don't have to do that. There's dose constraints that are used in NRG trials. I won't go through that, but there are now very well-established dose constraints that are published and used in the NRG trials that people can use, and these are going to be pretty good and very safe. So I think in this first topic, I think prostate radiation has now moved from 10 years ago where we treat people for 8 to 9 weeks, 40 fractions, 43 fractions, to moderate hypofractionation, which is 4 to 6 weeks, now to 1 week. And I offer this a lot to my patients. This is good for patients. We don't want to treat them for 2 months. We want to treat them for 1 week with similar, equal outcomes. I think prostate SBRT is very well established for low and favorable intermediate prostate cancer. It is absolutely safe, and actually probably even safer with rectal spacer that we use today and with modern dose constraints that are published. The patient benefit is convenience and also lower cost. There's more and more data, randomized data will be published soon to support prostate SBRT for low and intermediate cancer. There's now an ongoing phase 3 trial for SBRT compared to longer fractionation for high-risk cancer, NRG GU13. That won't finish for several years, so we won't have data for high-risk cancer, but certainly for low and intermediate cancer, there's a lot of data, and this is something that I offer a lot to my patients. Okay, so moving on to the second topic, which is oligometastatic prostate cancer. I'm going to discuss 3 randomized phase 2 trials, and I really do think that for patients who have oligometastatic prostate cancer, I think SBRT is actually, for the metastatic sites, is very beneficial to these patients. So 3 trials I'm going to discuss. One is ORIOL. ORIOL is a randomized phase 2 trial with about 54 patients. And these patients had recurrent hormone-sensitive prostate cancer with 1 to 3 metastases on conventional imaging. I think we often ask, well, how many metastases is oligometastasis? In this trial on conventional imaging, which is CT and bone scan, they included 1 to 3. So we have to interpret how many metastases on PSMA, which we'll find more. So it's going to be more than 3, I think, when we use PSMA. So I define oligometastasis for prostate cancer probably at 5 or 6, because conventional imaging up to 3, PSMA is going to be more than that. So they randomized these patients with 1 to 3 metastases on conventional imaging to observation versus SBRT treating the metastatic sites, no hormone therapy, and the primary outcome was progression-free survival, which is defined as PSA increase or conventional imaging progression or hormone therapy. This trial is very similar to the STOMP trial, and I'll discuss them together, but the STOMP trial is another randomized phase 2 trial with 60 patients. Recurring hormone-sensitive prostate cancer, 1 to 3 metastases on choline PET. Choline PET is also, I think, less sensitive than PSMA PET, but that's what they had for the STOMP trial. And they randomized these patients with 1 to 3 metastases on choline PET to observation or metastasis therapy. Most of these patients received SBRT to the metastasis, but a few patients received surgery for the metastasis, like lymph nodes, and 1 patient got a lung surgery. So no hormone therapy. So, and again, the primary outcome was some sort of progression. So ADT-free survival, and they would start ADT when there's symptoms, more metastasis. And so because these 2 trials are pretty similar in design and pretty similar in patient population, they actually analyzed them together. So STOMP and ORIOL combined their patients and published the 5-year results in JCO a couple of years ago with a median follow-up of 4.5 years. In the combined data, they looked at progression-free survival, radiographic progression-free survival, castrate-resistant prostate cancer, and overall survival. And so what you see here is on progression-free survival, treating the metastatic disease was better than observation. So all the dots on this side is better for metastatic treatment. So progression-free survival was better, and the confidence interval didn't cross 1, so that was statistically significant. Radiographic progression-free survival was also on this side, but not statistically significant. Castrate-resistant, not significant. Overall survival had a hazard ratio of 0.5, but very long confidence interval, so it's underpowered for survival, and that was not statistically significant. but it was better for progression-free survival. And you can see that on STOMP and ORIOL, showing that so oligometastatic treatment is better for progression-free survival. But what I think is even more important is this subgroup analysis of the ORIOL trial. So the ORIOL trial treated all the metastatic sites seen on conventional imaging, but they also did PSMA PET scans on everybody. And what they saw is that if all the PSMA PET lesions were treated with SBRT, this is the progression-free survival. And what you can see is that 60% of patients at 2 years had no progression when all the PSMA PET lesions were treated. That means that for patients who have oligometastatic prostate cancer, if we do SBRT for all the sites, we can prevent 60% of patients from having to have hormone therapy for more than 2 years. Not having hormone therapy for patients is a huge benefit because hormone therapy causes a lot of side effects. And if we treat SBRT for these patients to delay hormone therapy by several years, that really helps our patients. The toxicity is very low from STOMP and ORIOL. So SBRT is very safe. There's grade 1 toxicity. That was loose stools and muscle soreness, but grade 1 really is not very severe. Some also has surgery, and so of course with surgery you have a little bit more toxicity. But SBRT is very safe with low toxicity, and for ORIOL, also similar for SBRT, there's 1 incontinence, 1 patient had esophagitis, probably because of a lymph node somewhere, and then grade 2 dizziness. But these are very low rates of toxicity for SBRT. Again, preventing patients from having to have hormone therapy for a long time. The third trial I'm going to discuss in this topic is the EXTEND trial. This is another randomized phase 2 trial, 87 patients. This is a little bit different. The prior 2 trials was treatment with no ADT. In this trial, the randomization is intermittent ADT. They start with 6 months of ADT versus intermittent ADT plus SBRT. So people got 6 months of hormone therapy, and then you would stop. But then this one's got 6 months hormone therapy and SBRT. And then they follow these patients. These are patients with castrate-sensitive or castrate-resistant prostate cancer, 1 to 5 metastases on conventional imaging or cyclovine PET. The hormone therapy included 40% of patients who got second-generation ARSI. The primary outcome is progression-free survival. It's a very similar story. What they saw is that this is progression-free survival, and when you treat patients with 6 months of hormone therapy plus SBRT, there's much better progression-free survival compared to just ADT alone. And eugonadal progression-free survival means that after 6 months of ADT, they stopped ADT and patients had recovered testosterone. And after the testosterone recovered, the people who got SBRT still have 50% of these patients who did not have progression for more than 2 years. So you give them 6 months of ADT and you stop, the testosterone comes back and the SBRT is able to keep the patients free from progression and free from more ADT for more than 2 years, which is really beneficial. And the hormone therapy arm, once the testosterone recovered, there's more rapid progression requiring more hormone therapy to patients. So with these 3 randomized phase 2 trials, my conclusion is that SBRT for patients with oligometastatic prostate cancer is safe with mostly grade 1 to 2 toxicity in a small percentage of patients. And when all the visible metastatic sites are treated, 60% of patients can stay off of ADT for more than 2 years. That is a huge benefit to our patients. Patients don't like ADT, causes a lot of side effects. If a little bit of SBRT can keep a lot of patients off ADT, this is the benefit for oligometastatic treatment. There may be a survival benefit as seen on the STOMP and ORIOL analysis, but it was underpowered, so I'm not sure, but this is the primary benefit. And as I talked about before, how many metastatic sites still oligometastasis? Well, the trials use choline, PET, or conventional imaging up to 3. So with PSMA PET era, I think 5 or 6 sites on PSMA PET, I think will be reasonable to still qualify as oligometastasis in my practice. Okay, so the last topic is SBRT for primary RCC. I'm going to talk about 3 studies. SBRT for RCC is still relatively new, and this tags along very well with a GU case that Dr. King presented this morning in the case session for GU. 3 papers. The first paper is a pooled analysis from 12 institutions. It's published in Lancet Oncology a couple years ago. This, at that time, was the largest series for SBRT for primary RCC. 12 institutions, 190 patients, primary RCC non-metastatic. These patients are treated with primary SBRT, no systemic therapy. And this is still new, so the patients they had were older, probably not surgical candidates. Actually, most of them were not surgical candidates. Actually, some patients only had 1 kidney, and the median tumor size is 4 centimeters. This is a really important paper because it showed long-term outcomes for disease control and toxicity from SBRT for these patients. Now, as people know, RCC is usually thought to be radio-resistant, but with SBRT dosing, it's no longer radio-resistant when we give high dose per fraction. So what they show are 5- and 7-year outcomes in this series of 190 patients. Local failure at 5 years is 5.5%, and at 7 years, 8.4%. This, to me, means that with SBRT doses, the local control is more than 90% long-term. This is no longer a radio-resistant tumor. We can control it with large doses with SBRT. It's very effective. Distant failure, freedom from distant failure, 81%. So there's some distant disease. Cancer-specific survival, 92%. But more than 90% local control with SBRT radiation. This is actually also very safe. I make the same point that these are early adopters. SBRT for RCC is very, very early. There are still not yet very well established dose constraints and how we set up patients. And actually, I'm surprised at how low the toxicity rates are in this first large series. There's grade 1 and 2 fatigue, nausea, chest wall pain, but that's not very severe. 1% grade 4 gastritis, 1% ulcer, probably because it's still early. We don't know exactly how to settle the patient to avoid this. And the one patient who had this issue had a very high dose of small bowel, 54 gray in 4 fractions. And so this is kind of just a learning mistake. We still don't know exactly what to do with dose constraints. And so in the early series, there's a small percentage of gastritis and duodenal ulcer. Chronic end-stage renal disease requiring dialysis, 7%, which actually is pretty low and compares very well to people who have surgery for kidney cancer. They did a subgroup analysis of patients who have only 1 kidney to see whether SBRT is safe when a patient only has solitary kidney. And for this subgroup in this series, the average eGFR was 61 at baseline and decreased by 14.5 at 5 years, with a 3.6% dialysis rate. So even for patients with solitary kidney, SBRT to treat that 1 kidney with RCC is still very safe with a low dialysis rate. And they say it's very similar to patients who have 2 kidneys in this series. They looked at outcome by tumor size, and if you look at disease local failure, bigger than 4 centimeters, smaller than 4 centimeters. If you look at cancer-specific survival and progression-free survival, it seems like SBRT is effective for both larger and smaller tumors, at least based on this series. So as of a couple of years ago, this was the largest series out there, and showing that it's pretty good. I would also say that because they pulled data from a lot of different institutions, there's different dose fractionations that were used. 24 times 1, 70 gray in 10 fractions. There's all different kinds of fractionation people use, and there's still not a single standard at this point. And people had different ways to, for PTV, there's different ways to reduce motion. So everybody did different things. It's still very, very early. Since then, there's now a second large series that was just published this year online, and a separate multi-institutional series, 16 institutions, Australia, France, Italy, Netherlands, 144 patients with primary RCC treated with SBRT, no systemic therapy, mostly medically inoperable, some solitary kidney. So this kind of confirms the results from the other series. And they also show local control with SBRT to be, at 5 years, to be 96%. So very, very effective to use SBRT for RCC. Cancer deaths low at 5 years. It also confirms the low toxicity rates in this separate series, grade 1 to 2 fatigue, back pain, nausea, but this is not very severe. Grade 3 and grade 4, 1% nausea, 1% diarrhea, 1% dialysis, seems to be very safe for patients. And now, so those are two large retrospective series, and now we have actually a prospective trial, Fast Track 2, that was published in Lancet Oncology a few months ago. This is a prospective phase 2 trial in Australia, Netherlands. They treated 70 patients with primary RCC, non-metastatic, no systemic therapy. And in this prospective trial, they had more standard dosing. For a smaller tumor, it was 26 gray times 1. This still kind of scares me. It scares me to give 26 gray times 1. And for larger tumors, 14 gray times 3, which is also kind of scary. 42 gray in 3 fractions. But that's what they did, and this is what they're studying. Older patients, median tumor size 4.6. They did not include patients with GFR less than 30. It did not include larger than 10 centimeter tumors. On this paper, they reported local control to be 100% at a median follow-up of 43 months. So very, very effective to control primary RCC. Now 3 studies showing the same thing. Freedom from distant failure, 97%, cancer survival, 100%. I think renal function is always something that we worry about. So in this particular prospective trial, on average, the eGFR was 61 at baseline, and for the entire trial, they dipped to an average of 46 by about 24 months. But the renal function stabilized after 2 years. So after SBRT for RCC, there may be initial decline, but after 2 years, there's really no longer decline in renal function. 1 patient was on dialysis out of 70 patients on this trial. This patient had a baseline GFR of 34, so not a lot of room for decline before dialysis. They looked at, for these patients, looked at contralateral kidney function, which of course would not be affected after SBRT. Ipsilateral kidney function does decline, which is not surprising. Toxicity, again, very low toxicity in this now prospective trial. Grade 1, grade 2, fatigue, probably temporary pain. Grade 3, very low, 4% nausea, vomiting, 6% pain, 3% colonic obstruction. I think we are still learning how to minimize dose to the bowel when we're giving 26 gray times 1. I think this is still something we have to watch out for, 1% diarrhea. But even this is still very low rates of grade 3 toxicity for this treatment. So, and I think compares very favorably to surgery. I think surgery's toxicity is probably higher than this. So I want to just mention this. I think one thing that's important about kidney SBRT is that it's a thing that can really move during treatment. Kidney is close to the diaphragm, and during treatment for each fraction, there could be a lot of movement, intra-fraction movement during treatment as the patient breathes. This is actually a paper that I published many, many years ago now. I used to do kidney SBRT on a CyberKnife. In CyberKnife, you can actually track the tumor. So we looked at the data for 5 patients. So patient 1, fraction 1, 2, and 3. So this is a paper of 5 patients looking at how much movement they had in the 3 fractions of treatment for each patient. And this is showing the percentage of the time during each fraction where the tumor moved, the kidney moved more than 5 millimeters from the origin. And what the point I'm trying to make is that out of 5 patients, patient 4 had very little movement. Fraction 1, 0.3% of the time moved more than 5 millimeters. Fraction 2, only 5% of the time more than 5 millimeters. Fraction 3, 0.8%. So patient 4 had very little intra-fraction movement with kidney SBRT. But patient 2, 65% of the time, the tumor was outside of 5 millimeters, 78% of the time in fraction 2. So for each patient, there could be a lot of movement And for each patient, it could be a very little movement. That's something we have to watch out for when we treat patients with this technique. So SBRT now has enough evidence. It's now part of the American NCCN guidelines. And the most recent guidelines says SBRT may be considered for non-optimal surgical candidates with stage 1 kidney cancer or with stage 2 or 3 kidney cancer. It can be considered for patients with tumors less than 7 centimeters in diameter. I think that's reasonable. And some of the possible regimens that NCCN recommends, 26 times 1, 42 to 48 gray, which is 14 to 16 gray times 3 or 4 fractions, or 5 fractions to 10 gray times 5, something like that, either every day or every other day. Still a lot of room for people to understand what dose fractions are the best. It's still early, but there's enough evidence showing that this is effective and safe. It's now a standard option for our patients. So my overall conclusion for primary RCC SBRT, I think is very promising and should be considered for candidates, for patients who are not candidates for surgery or decline surgery. Patients who don't want to lose their kidney or have a major operation should be offered SBRT, which is very effective, has a low control rate of more than 90%. I do think we have to use SBRT dosing, so very high doses. I think moderate hypofractionation or conventional fractionation probably is still not going to be effective. I think we have to use large doses to control RCC. Multiple studies now show that this is effective, well tolerated, with relatively low, high-grade toxicity, but I think bowel dose constraints is still the number one worry that I have when I treat patients. I'm very conservative to not have high dose near bowel or stomach. I think intrafraction tumor movement is a big issue, and when we treat these patients, we have to try to minimize that. And that's it. I'm happy to take questions or comments. Yes?
I have a question about the margin about the prostate cancer.
Yes.
Because you mentioned about the tracking and also the fiducial markers, do you think the 3 to 5 millimeter is still necessary? And how about the machine you use?
Yeah, very good. So the question is about prostate SBRT, the different machines you use, and the margins. Yeah, I think, if you're able to track the prostate during the fraction, whether it's MR-Linac or maybe Calypso, and you know exactly how much movement there is during the treatment, you can probably shrink the margin. And there's, some data from UCLA that shows if you shrink the margin, there's less toxicity. So I think that's fair. And so the way I think about it, though, and I use Calypso, so I do track the margin. But in prostate SBRT, I contour the prostate as my CTV, and then I add a 5 millimeter margin, which includes extraprostatic disease and movement. It's actually two things. You can actually think of the prostate as GTV, and then the 5 millimeter margin is actually CTV and PTV combined. So it's actually still very tight, because some patients, if you have unfavorable intermediate prostate cancer, there may be some patients who have extraprostatic disease, which need some margin, and then you need setup difference and movement for a different margin. And all that's still only 5 millimeters, so I think it's still really small. So I think regardless of how well we track, something between 3 to 5 millimeters is probably still the smallest that I would accept. Yes?
Thank you, Dr. Chen, for excellent talk. I have two questions. One is for the prostate cancer with oligometastatic disease. When we treat all the metastatic sites, do you think that we need to push the dose limit to the to the limit for every site, or do you think is there a BD limit that we should give at least above, so that we can effectively control all the metastatic disease?
Yeah, that's a very good question. This is my philosophy. I think different cancers are different. Renal cell carcinoma is radioresistant. Prostate is actually pretty sensitive to radiation. And we know that from primary prostate cancer, 7 Gray times 5, whatever, is enough to control primary prostate cancer, which is pretty sensitive. So I think that even for oligometastasis for prostate cancer, we don't have to be very high BED for prostate cancer. For renal cell metastatic, I think we have to push BED a little bit more. But for prostate cancer, which is more sensitive, I don't think we have to push BED as much. So I start, if it's a bony metastasis for prostate, I may start with 9 Gray times 3 or something. I may go up a little bit, lower a little bit based on dose tolerance to whatever's nearby. But I don't think we have to push the prostate oligometastatic dose as much as kidney.
My second question is for the kidney SBRT. For the what kind of technique do you think is at least we need for kidney SBRT? Is it the respiratory control necessary? Is it okay to use our current technique, like
I think for kidney SBRT, movement is an issue. So, and I think we need to understand the patient's kidney movement as simulation. So I would do a 4D CT to understand how much movement, and I would try to do some respiratory tracking to see whether it's the respiration is related to the movement of that patient, because every patient actually is different. And so I think respiratory management, sometimes abdominal compression, I think are good techniques to use. And doing 4DCs to understand how much movement there is, I think that's important for simulation. I use Calypso, so actually I can actually see the movement during treatment, which makes me more comfortable. If you don't have Calypso, I use regular fiducials. I think abdominal compression, respiratory management, I think is important.
So in the current studies, they use the normal techniques, not the adaptive technique is not necessary.
Well, I think, the studies were published prior to the availability of adaptive machines, right? MR-Linac was not invented when those studies were done. I do think that now that we have multiple types of adaptive machines, whether it's a Varian product with Ethos or MR-Linac, I do think that insofar as those machines allow us to better understand movement and be able to be more accurate, especially for very high doses like kidney SBRT, I think that can be helpful.
Thank you very much.
Okay, thanks, Dr. Chen. I'm curious about the fiducial markers and the rectal, So I would like to know that, do you do the implantation of the fiducial markers by yourself or just by the GU doctors? Thanks.
Right, so for prostate SBRT, different people can do the fiducial markers and different types of doctors can do the fiducial markers and different people can do the spacing, the rectal spacer. In my department, the radiation oncology does all of that. So there's 4 of us, GU radiation oncologists in my department. We all put in our own fiducials and our spacer, and it's actually not very hard. It takes a little bit of practice, but it's pretty easy to learn, so we do our own. But other departments, you can use interventional radiology or you can use urology, but in my department, the radiation oncologists do all that.
So what about the rectal spacer? What kind of rectal spacers do you use?
Yeah, so there's multiple rectal spacing products out there. So there is Spacor, there's Barrigel, and then there's that balloon that has come out more recently. I think they all have pluses and minuses. I'm not sure that one is strongly preferred over the other. In my department, we're now using Barrigel as what we do for patients, but we're actually participating in a Spacor clinical trial, and so we'll be using those 2. For the clinical trial patients, it'll be Spacor. For the non-clinical trial patients, we'll use Barrigel. I think they're very similar.
Okay, thank you.
5 minutes. More time for questions. How many people do SBRT for prostate cancer? Oh, 2 years ago, it was less than that. That's good. How many people do SBRT for oligometastatic prostate cancer? Yeah, that's great. I think that even if there's no survival benefit, preventing patients from getting hormone therapy for a year or 2 or 3 or 4 is still a huge benefit. So I would argue for that. It's a very safe treatment for patients. How many people do SBRT for kidney cancer? Good job. Leader of Taiwan. Other questions?
Your talk is very impressive, but although I do not do the SBRT for prostate cancer, but we really try to use our particle therapy for the RCC. But you see that I know that the experience there is not good because the kidney will be slide. Yeah. Everywhere. Even you say that 3.8 centimeter. Yeah. So then we turn to use the SBRT.
Yeah.
I think because the SBRT can use multiple angle, but our carbon only have 2 angles.
Yeah.
So I think SBRT is a good choice for
Yeah.
the RCC.
Yeah, thank you very much. I think, yes. I think there are a lot of patients. I think for many cancers, surgery used to be the only option. And more we have data that radiation is a good alternative. So for kidney cancer, radiation is a very good alternative. People don't have to have major surgery if they don't want to. Bladder cancer, we talked about this morning. You don't have to lose your bladder anymore. Radiation chemotherapy is a very good option for patients. So this is very good for our patients who can have a good outcome without having to undergo major surgery and have good quality of life. If no more questions, we will stop here. Thank you very much, everybody. Hi.